Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam from Houston, Texas, and this is Cardiology Seminars. Our Triple N Media on YouTube channel has more than 170 lectures on cardiology topics. You're welcome to watch each one of those, and we do kindly request you to subscribe to our YouTube channel. At the end of the presentation, I'm going to tell you how you can get a free copy of my Cardiology Rounds Manual, which has more than 140 pages of chock-full information. Let us come to the main feature presentation, which is systolic versus diastolic heart failure. In the previous presentation, I talked about cardiac output, stroke volume, and diastolic volume, and systolic volume, preload, afterload, and please watch that video before you listen to the presentation on systolic versus diastolic heart failure, so that you have a much better understanding of the pathophysiology in various types of heart failures, their clinical manifestations, their examination, diagnostic studies, and management. So let us begin with the feature presentation. We have mainly two types of heart failures, namely the congestive heart failure characterized by dilated heart or dilated cardiomyopathy with increased volumes, low cardiac output, and heart failure. On the other spectrum, we have hypertrophic cardiomyopathy, where there is increased thickness of the heart muscle itself, or there is infiltration of the myocardium, leading to stiffening of the heart chamber, which results in decreased compliance, increased elevated end diastolic pressure, and a totally different presentation. As far as symptoms and clinical findings are concerned. The etiology of congestive heart failure could be any number of things. It could be idiopathic dilated cardiomyopathy. It could be due to viral infections. Most often it is related to coronary artery disease with multiple myocardial infarctions, myocardial fibrosis, grossly dilated heart leading to congestive heart failure. It may also be seen in patients with chronic renal failure. We have long-standing hypertension who start off with hypertrophic ventricle, then they go on to develop dilatation of the left ventricular chamber, leading to congestive heart failure. On the other hand, the diastolic heart failure, as I said, is caused mostly by hypertrophic cardiomyopathy, severe hypertension, aortic stenosis, anything that leads to increased systemic vascular resistance, increasing the thickness of the left ventricle, and thus leading to a non-compliant diastolic function of the ventricle, resulting in heart failure symptoms. As far as pathology is concerned, in patients with severe dilated cardiomyopathy, obviously we have grossly dilated left ventricular chamber and perhaps maybe also right ventricular chamber if there is associated pulmonary hypertension, and the left atrium may be dilated, and there may be even evidence of blood clots in the left atrial appendage in chronic heart failure patients with significantly reduced ejection fraction. So in patients with congestive heart failure, obviously we have dilated heart, increased end diastolic volume, increased end diastolic pressure with reduced ejection fraction, and reduced cardiac output, poor peripheral circulation, leading to various symptoms. In patients with hypertrophic cardiomyopathy, their heart size may be normal, their physical examination may be normal under most conditions, but when they decompensate due to volume overload or salt excess, they can develop acute pulmonary edema in a short order. So their symptoms are more acute in onset, whereas in patients with congestive heart failure, it may be slightly gradual unless they develop pneumonia or some other complications like myocardial infarction. Let's look at the symptoms. The symptoms presented by these two categories will be more or less similar in certain respect and different in many respects. In patients with congestive cardiomyopathy or dilated heart failure, they have ongoing recurrent symptoms of shortness of breath, fatigue, weakness, inability to walk any distance for that matter. They may also have palpitations if they have a history of atrial fibrillation or atrial flutter. They may have notice in weight gain, leg swelling, whereas patients with diastolic heart failure may be generally asymptomatic until they get into problem with either a myocardial infarction or excess volume overload or excess salt intake, which can lead to acute volume overload that results in pulmonary edema due to non-compliant ventricle to handle the excess volume. And these patients may also have cough or fever depending upon if they have an infection, or just due to pulmonary congestion, they may also experience wheezing. On examination in patients with chronic dilated cardiomyopathy and congestive heart failure, there will be telltale signs of increased jugular venous pressure. There may be rales and wheezing and rhonchi over both lung fields. You may be able to feel the apical impulse displaced to the left, suggesting cardiomegaly, and you may be able to hear S3 or S4 gallop. And if they have arrhythmias, you may also hear heart murmurs like mitral regurgitation or tricuspid regurgitation or pulmonary hypertension. Whereas in patients with hypertrophic cardiomyopathy, you may be able to not see jugular venous distension. You may not see peripheral edema, but however, their lungs may be flooded with fluid, causing rales, rhonchi, and wheezing. On examination, their cardiac size may be normal. They may have systolic murmurs, which may represent an obstruction to the left ventricular outflow tract, or due to increased resistance against which the blood has to be pumped. And patients with congestive heart failure may also notice abdominal distension, ascites, and edema. Let's talk about some diagnostic tests that will help us to differentiate these two types of heart failure. Electrocardiogram may show evidence of left ventricular hypertrophy in both cases. It may show evidence of atrial fibrillation or atrial flutter or ventricular premature beats, so it is not of much help. Chest X-ray may show a gross cardiomegaly in patients with dilated heart cardiomyopathy and heart failure, whereas in patients with hypertrophic cardiomyopathy, the heart size may be normal, but both these conditions can show evidence of pulmonary edema or pulmonary congestion. In addition, you may also see evidence of pneumonia or atelectasis related to infection. Echocardiogram is the most definitive test to differentiate between congestive cardiomyopathy and heart failure, congestive cardiomyopathy related heart failure versus hypertrophic cardiomyopathy related heart failure. Of course, with the echocardiogram, we can look at the ventricular size, thickness, volumes, and also look at the valvular functions in terms of regurgitation or stenosis, whatever the case might be. And once we have done the initial examination, looking at the lab tests, which may show evidence of myocardial ischemia or infarction, and kidney function, electrolytes, potassium, magnesium, then we may have to do certain provocative tests like stress nuclear studies to look for any evidence of myocardial ischemia in patients with coronary artery disease and EKG changes or mild elevation in cardiac enzymes. Management of these two patients is slightly different, and I'm going to just highlight some of the main features. You can look at any books. The 1,000-page book has been written on just heart failure, so you can imagine how much information we have to digest in order to be able to differentiate between congestive heart failure versus diastolic heart failure. In patients with systolic heart failure, obviously the treatment would be to give them intravenous diuretics. If they are on a large dose of diuretics orally, you give their 24-hour dose of diuretic as a bolus and follow up with intravenous diuretics at intervals or a continuous drip such as Lasix drip. And we also need to closely monitor their volume status and also their electrolytes like potassium and magnesium and replace them as necessary. If patients are having chest pain and EKG changes, nitrates may be an appropriate choice to use, and nitrates are also useful in reducing the end diastolic pressure and relieving some of the symptoms like acute shortness of breath. Beta blockers, one word of caution as far as beta blockers are concerned is to make sure that the patient is euvolemic. That means the volume status is back to baseline before we give the patients with before we treat patients with beta blockers. ACE inhibitors and ARBs are the mainstay of treatment in patients with systolic or diastolic heart failure to reduce the systemic vascular resistance, to improve the forward cardiac output. But we also need to keep in mind any evidence of renal function that has deteriorated, where there is increased creatinine level, where we may have to be very judicious in using ACE or ARBs. We may have to get their volume status fixed. We have to get their renal status corrected before we really push high doses of ACE or ARBs. In patients who are with a diagnosis of kidney failure, who are on dialysis, we have to decide what's the best time to do the dialysis to remove the excess fluid and thus relieve some of the symptoms related to volume overload. Blood pressure control and heart rate control are exceedingly important in both systolic and diastolic heart failure patients. Some of these patients may have evidence of myocardial ischemia or non-transmural myocardial infarction, and they may be started on blood thinners like heparin or Lovenox. And daily monitoring of their weights is of great importance in trying to see how these patients are responding to the treatment. Based on this initial assessment and treatment, then we try to make a definitive approach as well if they need any cardiac catheterization or any other procedures to address the evidence, to address the question of myocardial ischemia or significant coronary artery disease. Once the patients are stabilized, we need to maintain them on a proper medical regimen, which needs to be continued on an outpatient basis and followed up very closely. 24% of these patients are readmitted within 30 days. That is across the nation, the statistics, which is really mind-boggling. So it is not just taking care of the patient for 2 days in the hospital. Our management has to be long-term, and we have to make sure that the patient understands the list of the medications they are supposed to be on and follow these patients within a week or two after they are discharged so that you avoid readmission to the hospital within 30 days. The ability of a primary care doctor, a cardiologist, depends upon how well this person understands the pathophysiology of a heart failure, be it systolic or diastolic, and manage it in the hospital and also keep these patients out of the hospital. So, ladies and gentlemen, this is a quick synopsis of how you evaluate and manage patients with systolic versus diastolic heart failure. And this has been a presentation of the cardiology seminars brought to you by Triple N Media. I am Dr. Nik Nikam from Houston, Texas. And if you would like to get a copy of my cardiology rounds manual on how to survive cardiology rounds, you can just send me an email at drniknikam@gmail.com, and I will be happy to send you a free complimentary copy of this book. And please do subscribe to our YouTube channel, and I will see you next time.